Good afternoon, everyone. Good morning, good evening. Gareth Presh, founder of the World Health Innovation Summit and CEO of the Global Social Prescribing Alliance. Welcome back. I hope you've all enjoyed lunch. I certainly have. I got a quick walk in as well. So let's take a deep dive into our global case studies this afternoon. We've got a stellar lineup this afternoon. Our newly appointed chair is here. We have Jill, who's doing amazing work in cities all over the world. Rini, who's pioneering fertility clinics in the Middle East, and then Sheva and Robert, who are just doing outstanding work all over the world. And super excited to let them share their stories and words of wisdom. We'll just start with a short round of introductions, and perhaps we'll go to Sheva and Robert first. The stage is yours, Sheva and Robert. And I have to also say thank you very much for the sponsorship. The Fyera Foundation sponsored this event, and I am truly grateful for that. Without that sponsorship, this event would not take place. So thanks again, Sheva.
It's been a privilege and an honor for the Fyera Foundation to be a sponsor of this amazing work. And a privilege and an honor to know you, Gareth, and everyone here on the panel. So Robert and I are the co-directors of HeartMath Healthcare. We're also co-vice presidents of a UN Peace Messenger organization called Pathways to Peace, and the Fyera Foundation, founding executives there, where we have ECOSOC status at the UN and also policy right for the G20. And that's something we're very eager and excited to share with you. Then we have a global community of heart ambassadors who get to experience the benefits of social prescribing with each other and be ambassadors of that for the benefit of the world.
And the foundations of our work on the HeartMath side of things is really about how you bring heart coherence into all the various modalities and how do you operationalize that into the field. And so we have some amazing case studies that have been replicatable over time in all industries, in all sorts of cultural settings, on how when you get a human being to self-regulate and come from the heart, how it can help optimize health and performance in all sorts of ways. So we'll highlight a few of those for you today.
Yep. Don't be so modest, but also tell us about this Well Futures Alliance, because we just published a G20 paper today. So please, by all means, share that.
Well, we're honored to have founded with Gareth and our partners at Harvard's Mental Health for All project, the Well Futures Alliance, which has lots of plays and words there, because we are dipping into the well of human resources to improve human quality of life and create better futures for all, with a new take on old financial futures, where we're really investing not just in capital wealth building, but in the most important resource of all, which is the capital of life within our biosphere, and it's thriving.
Wonderful, wonderful. Let me go to Professor Jill Litt. Jill, I know you're in Colorado as well, so good morning. You're on mute.
Thank you. Sorry. It's wonderful to be here. Thanks for this opportunity. So I will be talking about, I've been leading a Horizon 2020 project. I'm an environmental epidemiologist based in Barcelona at the Barcelona Institute for Global Health since 2016. And during that time, and so on leave from University of Colorado, and during that time I've been leading a Horizon 2020 consortium initiative called RESETHUS, which it stands for Reimagining Environments for Connection and Engagement, testing actions for social prescribing. So we just concluded the project at the end of June, and now we're kind of busy getting the results out. So I'm happy to share some of those results today.
Thanks, Jill. Wonderful work. Let me go to the Middle East. Rini. We can't hear you for some reason. Oh, we still can't hear you for the moment. What we'll do is we'll pop to Jim and see if we can. I'm just getting feedback as well. Jim, can you hear us okay?
I can hear you, but I'm getting some kind of feedback from another speaker, it seems. Can you hear me okay?
I can do. If anyone's playing YouTube in the background, maybe disconnect it. That could be what it is.
Can you hear me now?
Perfect. Go ahead, Jim.
Oh.
We're just on the intros.
Can you hear me now?
Please, go ahead.
Okay, great.
Go ahead.
Okay, great. Yes. Hi, everyone.
I will just say that we are so blessed to have been able to bring Jim into the fold of this work. Jim, we would love it if you would introduce yourself. Of course, we met you through our collaborations at Kaiser Permanente, but you are a healthcare futurist, the first person that we ever designated such. And so I would love it if you would introduce the more that you are, Jim, for the audience.
Thank you. Yes, well, thank you for that.
So Gareth, we could go ahead with the introductions, and then we'll go into the questions that you have.
Yeah, I'm just hearing. I'm hearing everything.
Yeah, sorry. I think we're having some technical problems. Apologies there.
Right.
No problem. Let me try bring Rinny back in, and then I can go back to Jim, and then we can bring in Patricia. Rinny, can you hear me okay?
I can hear you. Can you hear me now?
Perfect.
Oh,
That's
good.
much better. Great stuff.
Good stuff. Okay, so Rini Lasker, founder of the HEAR Women's Wellness and Fertility Network in the UAE, and I'm also the owner of the Doctors Hub Polyclinic. My talk mainly today will focus on the women's wellness aspect of women's fertility and the IVF journey, but I do have a background in corporate governance and banking.
Fantastic. Thank you very much. And let me go to Patricia. Hopefully the technical issues have sorted themselves out. Patricia?
Yes, can you hear me?
Yep, perfect.
Okay, excellent. Hi, I'm Patricia Welch Saleeby. As of this morning, I'm the newly appointed chair of the Global Social Prescribing Alliance. I'm very excited to continue my work. Thank you. I'm a professional social worker. So we've been doing social prescribing, whether we want to call it that or not, for a long, long time. And we address social determinants of health in the community. Today, I'm going to talk a little bit about how we are working through projects related to health interoperability and how we're using these classification systems to capture functioning, the environment, including social determinants of health. So I'm really proud to be talking about how we are merging the work with my WHO project, classifications that address these critical factors that are relevant to social prescribing, and then showcase it through two specific projects known as PASIO for post-acute care and Gravity for social determinants of health. And those are both Fyera interoperability projects. So excited to be here and add to the discussion.
Thanks a million. So hopefully this will work, Jim. I'm delighted to welcome Dr. Jim D'Alfonso. He's one of our global ambassadors, but he's also the chair of our WHIS initiative in the USA. So Jim, absolutely delighted to hand over to yourself, and hopefully this technically will work.
Well, I can hear everybody. As a matter of fact, I hear everybody twice. So I'm getting double feedback from everywhere. I'm thrilled to be here, and thank you, Sheva and Robert, for that kind introduction as well. Okay.
Okay, brilliant, Jim. Let me go back to Sheva then and Robert, and maybe give us an insight into the work that you're doing just at the sort of global level. You know, we want to look at closely, like, you know, how do we build the case for social prescribing? And also, I know I mean, I've been reading over the last couple of days. I think I sent you a link around the HeartMath work that you've been pioneering. You know, how do we bring that to scale? You know, we need the data. We talk about this, and how do we bring it from a local level to a global context?
Well, I always think it's important to start looking at the global context at the very personal context. And so I'd love to invite everyone listening just to imagine, what if we had a magic pill for you? You don't have to swallow it that big. It's free. It's in everyone's capacity to access, that would lower your blood pressure equivalent to 2 years of pharmaceutical intervention, twice the impact of going on a salt-restricted diet without having to do that, equivalent to a 40-pound weight loss and exercise program without the weight loss or exercise, that would also balance your blood sugar, minimize your risk of ever getting diabetes, reducing your risk of cancer, even if you had HIV, reducing the risk of it turning to full-blown AIDS, and improved your mood, lowered your depression and anxiety, improved your sleep, reduced your aches and pains, facilitated more loving relationships in your family and in your personal life. This pill does all of that for you and for all those you love. Oh, and did I forget the rub? It's got no side effects. How many of you would actually want this pill for yourself, your loved ones, in the world? I see Patricia's in on this. Those are just some of the measurable benefits of this work. Oh, did I forget to mention it also reduces your risk of communicable disease acquisition. Even if you're exposed to COVID, you might not get it because of the enhancement to your immunity, all of which has been published and measured. That is the work of the HeartMath Institute. And these simple skills that people learn to self-regulate their heart rhythms and their emotions and get along better with each other and have more fun.
And what's really wonderful about this, Gareth, to your point of global scalability, is that, so much of the world is in a bind right now, where we feel like the only solutions that seem to be quote unquote effective need to be done by a clinical provider. And so these tools can go viral. They're all evidence-based, grounded in science, first, published in American Journal of Cardiology in '95, but you don't need to have a clinical license to share it. We can get each other's backs in the field, on the ground, on the street. And we
have children teaching one another peer-to-peer.
Exactly. And what we've seen is that when the steps to self-regulate heart rhythm patterns based on emotional self-regulation are predictable, if you actually just follow these very simple steps, and they're very easy to just pass on to anyone, you can disengage, physiologically speaking, mentally and emotionally, from these stress triggers. And we're all swimming as humanity in a sea of stress triggers. Every time we turn on the news or look across the street, it's the physical toll and what that takes on our community's psychic health, emotional health, mental health, all levels of health. It takes energy to run that. When we can bring our nervous systems back into balance and help support each other to do that, then we can re-engage with society with more of our innovation and our creativity, and even have more energy to do all the other beautiful things that social prescribing wants us to, encourage us to do. We have the energy to get off the couch and choose the right things to eat, and to do those exercise things together, and to bond socially. But if we don't have the energy at our core to do so, it's harder. It's more of a strain to even to engage.
It's really neurophysiologically flipping the switch of our operating system from surviving mode to thriving mode. And when we do that as individuals, then it ripples to what at HeartMath, that individual coherence, physiological coherence, becomes social coherence. And eventually, you asked about scalability, Gareth, becomes global coherence. And so we have done this at scale in large organizations. Kaiser Permanente, for example, is our largest single internal intervention. We have over 200 certified trainers within Kaiser and thousands of employees that have been impacted, as well as patients. But this is what brought us to policy work at the UN and at the G20, where because of the 35 years of powerful data that HeartMath has given us on this magic pill that is free and available and accessible to anyone who learns how to use it, we were able to ratify policy and contribute to the efforts to write this policy at the G20 in 2023 in India, lifting those types of skills we use in social prescribing, like HeartMath interventions, on par with literacy and numeracy as foundational requirements of learning for all education and employment in the G20 countries. So when you see that you can change an entire organizational culture, like a healthcare system with 350,000 employees, then it becomes evident that you can do this at the municipal level, at the state level, and we are in dialogue with nation states now who are vying to be the first country level to implement this work across the continuum of their populations to demonstrate the impacts on national health and well-being, public health and well-being, but also the economic impacts, which, Gareth, you are such a resounding expert in speaking to the cost savings and cost benefit to how this thriving changes how everything works in a society.
Yeah, brilliant. Well put. But I have to bring in Jill here at this point, because Jill has been doing Horizon 20 projects with cities and municipalities all over the world, but also bringing in the nature-based solutions. So Jill, maybe you could give us some context, because this is where it really gets supercharged, because we bring in nature, technology, and this is the future, because 80% of the social determinants of health is outside the health system, and that's where the opportunity lies.
And I, as you know, disappeared. Sorry about that. Do you want me to go into the details now about the studies? And
please, that'd be great, just to give people context.
Okay, so apologies, everyone. Major Google snafu. So our Horizon 2020 project was dedicated to testing social prescribing pathways to alleviate loneliness and promote health-related quality of life. And we also, in adjacent to these studies, we had a very robust cost effectiveness study ongoing in 3 of our randomized controlled trial sites. We developed decision analytic models and an evaluation of the social return on investment. So these were all kind of working together. And we've been in funding modes since 2021. The 6 cities that we've been working in extensively through a social network analysis process, co-creation, feasibility studies, randomized controlled trials, or pre-post studies. All of this kind of was mirrored in the 6 cities, which were Barcelona, Marseille, Prague, Helsinki, Melbourne, and Cuenca in Ecuador, not Cuenca, Spain. We recruited 1,200 people into our studies. Again, 3 were randomized controlled trials. And we designed an intervention called Friends in Nature. So it was designed to be a social prescribing pathway, distinguishing it from other studies or other social prescribing pathways because of its holistic approach. It's group-based and facilitator-led. It's also longitudinal, so the intervention is 10 weeks. So participants were screened for loneliness in a provider setting, usually a primary care center. We worked really closely with each of these entities in the 6 cities. And then they were assigned to a group, and that group met for 10 weeks, 2 hours per week. And all of these weekly sessions emphasize group dynamics, supporting the alleviation of loneliness, and nature-based, which is a pro-social environment, also supports emotional well-being. That we saw this as a facilitator, nature as a third facilitator, amplifying the group dynamic effect. Our populations that we recruited were highly vulnerable. Many were marginalized. They were diverse in age, social backgrounds, economic backgrounds. The geographies were really different. Vulnerabilities were different. We had refugees and asylum seeking young LGBTQIA plus community members to frail older adults in Helsinki living in assisted living facilities to highly vulnerable adults across the adult lifespan. So what did we find? So I'm happy to say that we were able to show that this intervention was effective in all 6 cities, reducing loneliness from baseline to follow-up at 3 months. And then in the trial sites, we were able to see this continued improvement. So not just maintaining, but at 6 and 12 months, we saw it increased over that year following the intervention for people's reductions in loneliness. So we were able to show that the group model is effective. In 2 of our trial sites, we showed actually that both the treatment and the active control, which was a signposted intervention, improved significantly. When we delved deeper into this, we were able to answer the question of who gets a group. When is a group necessary? Not everybody can deliver a group intervention. But we showed that the group model worked best for those with greater emotional needs. So they were less emotionally resilient when they came into the intervention, and they had higher levels of baseline loneliness. Those members, those participants benefited more from a group intervention. We saw more effectiveness in that arm. The signposted intervention was effective for those who were more emotionally resilient, but maybe just having like a passing level of loneliness. This is promising and interesting, not only for clinics, but also for collective health insurance environments where maybe in workforce interventions or workforce strategies, this could be something that could be very helpful for people having this kind of intermittent, less chronic condition of loneliness. And then I'll close with the good news economically was that we were able to show in our trial sites that the intervention was cost effective, that it generated social value over the 1-year trial period. And those results are coming out, have appeared in journals and also in review. So I'll stop there.
Thanks a million, Jill. Fantastic insight into giving a global context and being able to summarize that in like 3 or 4 minutes. Wonderful stuff. Jim, it'd be great to have your insight into sort of, I'd very much like to see what you think the future will look like, particularly with these new interventions and how we shape that future.
Yeah, thanks, Gareth, and apologies again for the technical challenges, but I think we're good now. It's a pleasure to be here, and thank you to Robert and Sheva for their kind words as well. I do work in a very large, integrated, not-for-profit health system in the United States, but more importantly, I'm a nurse. And as a nurse, I carry a social covenant. I'm a part of a worldwide global initiative to care for our and serve our public. And so I think that's my driving force more than anything. I think my 40 years of work in healthcare have been totally directed toward helping people access and mobilize their abilities to flourish. And Nightingale, Florence Nightingale, you know well, Gareth, from your UK days, but 150 years ago, she was basically saying, let's put the patient in a position where nature can heal them and put them in the right relationship. So I think we're still on that journey 150 years later. And I think the shift is really moving our systems and our professionals to beyond, prescribing necessarily, if that's the description, to more about activating them as part of their covenant. So this is not something that they add on to their current practice. It should be integrated into the whole. So when you talk about wholeness of the individual that we're hoping to serve, it's also wholeness of the practitioner. And a lot of the pandemics and issues we have around burnout and stress and the healthcare systems that are broken and not doing well around the world. Nurses are the largest part of that workforce. They're expected to endure. And I think Sheva and Robert's work is a really good example of lifting that off of the shoulders of care providers and helping them realize it's really about you're the heart of healthcare, not the shoulders or not the backbone. And so that's been the focus of our work for many years. I think social prescribing is something nurses have been doing for generations. And I think it's something that they need to take a whole new role in as a part of their work that is beyond the medicalized systems. It really returns us to the community. It helps us understand the importance of human flourishing, not just for others, but for ourselves as a unitary whole. And so I think, we've done a lot of work. We have a lot of opportunities going forward. And I think that's the excitement for us, is making that shift where we're out activating and actively connecting people, communities, and services so that our people can achieve their optimum health. And I would finish it by saying, if there's a lot of things we can remember, but, it's about humanity. And our work is about humanity, and it's an important, underscored, important, critical part of who we are as fellow human beings in this world. And it is a crazy world we're living in. So no greater time than now for us to all lean in to what this work that James and you have created, Gareth, and now for Patricia to pick up the mantle of this is so exciting. I've gotten so many people interested because it has meaning. It adds meaning and hope. And in business, you'll hear people say lots of things, but one of the things they say is hope is not a strategy. And in a presentation I'm preparing for the Mayo Clinic, where now the title of that is "Hope May Not Be the Strategy, but it is the antidote." And so that's where our work is focused.
Brilliant, Jim. I think this goes back to the foundations of the why. Peter was using Simon Sinek's point of view earlier, saying like why. And this goes back to the principles. The reason why I joined the health service, the reason why I do what I do, it's similar to everyone on this call, I'm sure, is because we want to help people. That's the fundamental principle. It gives us purpose. That's what we want to do. That's what draws us to this work. And that's what embeds the resilience within us. That's a fact, because we have a purpose. The more we help people, the better we feel. That's certainly on my side. I love that opportunity to be able to help people, to share knowledge, to share experiences, but then also to learn, to listen. I mean, it's an absolute privilege to work with colleagues here online, to learn, soak up the information, learn from experiences. And now let me just bring in Rinny, because Rinny's embarking on this from a different perspective. And I think it's so important we listen to Rinny, because she's coming from an external perspective, but also bringing that drive and innovation from a banking sector perspective. So super excited. Rinny, please share. And of course, we're looking forward to supporting you and the pathways within the Emiratis and the GCC through social prescribing, so they can access your clinics.
Thank you very much, Gareth, and wonderful to hear from some of the other folks on this call. Very inspiring. So my case study starts with my own personal journey of the IVF process that I went through about 13 years ago. I spent about 5 years trying to get pregnant. And when I spoke to the doctors and the physicians, many of them said, you need to wait a year before we can truly determine that you are infertile. And in that year, if a doctor had turned around and said to me, well, you know what, you don't have to start IVF now, but you could start by focusing on your nutrition, your lifestyle, your stress, I think, the results may have been a lot more different. Anyhow, I started IVF. I didn't take it as seriously. When I say I don't take it seriously, it's just, I had no idea of what the journey would entail. And I had no idea of how intrusive, how invasive, and how many injections were involved in the whole protocol. And when I went through it, I was quite, you almost feel a bit traumatized, by the end of the cycle. And unfortunately, it didn't work. And when I say I didn't take it quite seriously, on the day I had the egg implantation, I actually took a flight home. thinking, it's okay, medical science, you know, I'll just pump my body with medications and drugs and everything will be okay. It failed. But 1 month later, I naturally became pregnant. I had been taking acupuncture and I was on holiday with my friends. So it was a complete surprise and the best, you know, present that God could have ever, you know, granted me. I went through the cycle a few more times and I wasn't quite successful. However, I spoke to a number of my colleagues in banking and other sectors. Now, one lady I worked with, she was 43. She had 3 failed IVF cycles. She'd completely given up after her last cycle. She went on holiday to Hawaii for 3 weeks, came back pregnant, gave birth at the age of 43 to a healthy boy. More recently, and when I moved to the Middle East, again in banking, I spoke to some colleagues very stressed out with their day jobs, and I was advising them about how I became pregnant naturally. I actually had IVF again, and I did become pregnant, but it wasn't successful. And I was a lot older by the time I did that second IVF protocol. But this friend had 0 eggs. She went to Bali on her own without her husband, did yoga, did acupuncture, did all sorts of, you know, wellness, holistic therapies, came back and had 10 eggs. The doctors in her case wanted to actually do a study just on how did this happen in such a short space of time. And I realized that there was an opportunity here. And a couple of more things. So being in the Middle East, we have, you know, a relatively conservative society, but a lot of the fertility clinics here are male dominated. No disrespect to the doctors. I think some of the physicians are absolutely fantastic. However, not always understanding what the experience or the journey is like for a woman going through this. It almost feels sometimes a bit like you're a factory. You go in, and even being examined in this region by a male doctor as opposed to, you know, a female doctor. Again, no disrespect to male doctors. My grandfather was a gynecologist. You know, it's quite, you know, it's not offering women the choice or thinking about some of the cultural aspects. So here, Wellness, Women's and Fertility was conceived because we wanted to have this run by women for women, with women who have the lived experience. We've been through the journey. We know that to start IVF on day 1 is perhaps not the best approach. You need at least a 3-month, you know, run up before you can mentally, physically, biologically be ready for the actual journey. Yeah, that's a bit of background. I mean, look, there's lots of data and stats out there that support doing things like acupuncture, alternative therapies, yoga, cognitive behavioral therapy, that overall it does determine the success of IVF. There was a very famous study by Dr. Alice Domar from Boston IVF. On the second cycle, for those participants, over 5,000 women who had done yoga and CBT, they were 52% more likely to result in a live birth as opposed to 20% in the control group. So there is some real, you know, data suggesting that this is very, very credible. And the other final point about the Middle East focus is that there are more women working here in the Middle East or in UAE compared to the global average. So 56% of the women are in the workforce. The demand for IVF is increasing because, you know, more women are working. They're spending less time, you know, at home with families. The water quality here, unfortunately, again, it's all desalinated. We're constantly in AC. You know, the lifestyle is quite luxurious. You know, there's valet parking. You don't walk as much. So there's all sorts of Middle East factors. So when we come up with a pathway for a woman who's about to embark on the IVF journey, we have to consider all of these different variables, including the geography, including where she is, including her lifestyle, including her mental well-being. So that's a bit of the background to this initiative.
Thanks a million. And it's important to stress the link here to social prescribing, because it is quite, there is a huge link here, because these are new pathways that we're creating. And it's important to understand that with Rinny's support and other colleagues. We have a GCC representative, Nora Al-Suadi, who I'm working very closely with, and we are engaged with a number of governments in the GCC region on how to implement social prescribing at scale so that we can create those pathways into fertility clinics. So this is all new. This is the point I'm making around the future of healthcare. I think it's very exciting for me personally, who's worked in the health service, to have this fresh approach, this new ideology coming from Rinny's side, who stepped out of the banking sector. And also it shows, you know, Jim, Sheva, Jill, Patricia, that the support and help is there, that people want to help from external agencies. They recognize that we are under severe pressure and that they're willing to give their time, expertise, and energy to make those changes. So this is where the great need comes, because we have 4 billion people who don't have access to healthcare. We have, it's arguable, the 4 billion that don't have access to healthcare, because certainly in the UK, we have 7 million people who are waiting on elective surgery. So this is an enormous problem. Women's health, the foundation, you know, only 2% of investment money is flowing into women's health. This is a massive problem and an opportunity. Patricia, listening to this, I know you have multiple programs and projects across the UN and WHO. Perhaps you could give us an insight into the work you're doing.
Sure. But I want to first just say, wow, we have just heard some amazing examples of social prescribing happening around the world, evidence-based, such impactful outcomes. So thank you for sharing. Now imagine, and I did tell you we're going to shift the conversation a little bit about how we're going to try to build a system to better capture social prescribing. So imagine if we could capture and communicate all this data from provider to provider, let's say patient to provider, and back again between settings in a much more uniform way. And imagine being able to actually getting insurance coverage and reimbursement for these social prescribing interventions that we heard about. Well, fortunately, the architecture for all this is already being built. It's known as health interoperability, which uses standardized classification and terminologies to connect medical providers, doctors, nurses, social workers, community health workers, other community care providers. And without this digital infrastructure, our best community interventions, some of the things we just heard about, will remain fragmented, and many will be invisible, unmeasured. So we need to look at these data standard projects, and I'm going to talk a little bit about that today. You think about health and social care interoperability. I say health and social care interoperability because I like to provide an extension of both those things when we think about social prescribing. But if you were to take a social prescription, you think about it, it could be a blind handoff, essentially, when a doctor, a nurse, a social worker would write a referral on paper, which they often do, and a clinic never learns maybe if the patient really attended the program. Did they actually do the intervention? And that community-based organization that's on the receiving end might not be able to share the progress back that goes back into perhaps the medical record, the electronic health record, and so forth. So by using a standardized classification of terminology, and we're building this, I'm going to talk a little bit about these Fyera projects that we're doing, we are able to transform kind of these vague descriptions, if you will, into structured data. And it allows us to integrate this system to track outcomes and measure the clinical value of all these social prescribing programs and interventions. It allows us to automate the screening, to flag risks before they perhaps become medical emergencies. So that emphasis on prevention rather than reactionary programs, which we know just don't work. And maybe even secure funding for proving to payers that social prescribing, these social prescribing interventions, reduce things like hospital readmissions. They improve clinical and patient outcomes. They improve trust between the patient and provider, and things that we already heard about today in terms of kindness, for example, well-being, as Jim mentioned, human flourishing. So you think about systems like, I work with the WHO, we built a classification on functioning, disability, and health. It has all aspects of functioning, so it moves beyond diagnosis. Everything that we just heard about today is captured with a unique code in terms of the functioning of human functioning and the environment, which is really exciting, that we can find an environmental code, if you will, for everything that we just talked about. When we think about isolation and loneliness, and if someone were to prescribe going to a social club, for example, we can find that. We can find activities and participation with social clubs We can find nature under the environmental codes. We can find anything related to kind of the traditional kind of classic examples of social determinants of health, like housing insecurity, transportation, lack of insurance, all again in the environmental sections of the ICF. And what we've been doing in what's known as FHIR, Fast Healthcare Interoperability Resources, are 2 projects. One is called the Gravity Project, and it's specifically capturing and standardizing social determinants of health data. It enables us to build data elements using a variety of terminologies and create implementation guides on how we can screen for, how we can document, and how we can intervene with social risks. So I'm going to come back to everyone after this today's summit, because I want to be able to try to pull in all these interventions as perhaps drop-down menu interventions, if you will, in an electronic health record, which would be pretty awesome. And then the PASSIO project is also working under FHIR. That stands for Post-Acute Care Interoperability, and it's really looking at how we can communicate and capture data between clinical settings. So from hospital discharge into, let's say, a nursing home or a rehabilitation, and then back to someone's home, being able to have those seamless transitions of data and being able to capture and better understand in terms of tracking, monitoring, functional capabilities, and then what in the environment is permitting this. If we're seeing an increase in functionality for a person, what is going on? Well, perhaps it's a social prescribing intervention, like one of the ones we just heard about. Maybe they're going on a nature walk prescribed by someone, some of what Jill said, or they're using the HeartMath, amazing HeartMath program as an intervention. And we're able to see those changes. We're able to capture it all again uniformly in a standardized way and being able to communicate this in the system. So it's just really exciting. I think Gareth is we're going to be able to share some of the links. We actually published a recent paper around the social prescription, health interoperability, where we see this synergy, and then really building a connected ecosystem so we can move away from this fragmented anecdotal care into a kind of data-driven, evidence-based, holistic, patient-centered healthcare system. So I'm going to leave it. There's a lot there to unpack. I'm going to leave it now and hand it over to Gareth. But thanks so much for allowing me to talk about these exciting projects.
Super stuff. Yeah, that's brilliant. Thanks a million. And just on the point, I think it's very important to bring in probably Jill's perspective from a nature perspective, just some of the learnings, from your side, Jill, and then I'll go to Sheva, and then Jim, and then Rini again. Oh, need to unmute. Oh, geez.
I have been thinking about this as we've closed the research and really been thinking about impact and translation and scaling. So some of the things that we are really focused on, one is the training. So we have a validated training model. And what we have heard a lot from clinicians and practitioners is that they need the accreditation and certification to be able to offer these. And this I'm speaking mostly from a non-US perspective, and also not a UK perspective. So we're trying to scale and create the mechanism to be able to to carry out this theory-informed, practice-based, and with a lot of mentoring for facilitators through our Friends in Nature training model. That's going to be really crucial. The other thing is that we have developed the technology, like software as a service, digital platform that's sort of end-to-end, working with providers, facilitators, clients, lonely people who are receiving this intervention, and third sector organizations. So scaling this is really crucial because we've heard from providers and those who are carrying out these programs in the hospital and primary care settings is they need the structures to be able to monitor, to track, to interact. And what we've also seen is what's really good news is this intervention sustains and even improves long after the intervention has ended. To have another aid in this, facilitating how these groups continue to meet outside of the intervention, the software is set up to facilitate that in a curated environment. The other path that we've been really focused on is ensuring that the policy is in place that guides this kind of adoption and implementation. So we've been working closely with nation states and also regional and local municipalities, and focusing on policies, for example, to recognize loneliness as a crucial public health issue. Recetas was named as a best practice in the national strategy that was just adopted in Spain, for example, and then the municipal strategy in Barcelona has been updated. This is also happening throughout municipalities in Spain and elsewhere. These discussions are advancing quickly in France and in the Czech Republic. Australia obviously is out there super engaged in recognizing this, but this is really important to have the policy piece in place because they need to work hand in hand. And then finally, you cannot do this without multi-sectoral engagement and co-creation, because these designs of these programs are going to look and feel differently. And as long as the elements, the core elements are similar, it's very agile and it can adapt this. So the combination of these strategies is really crucial.
Yeah, fantastic. Thanks for giving us the insight as well. I think it's important to get the context from different jurisdictions and the progress that's been made. And again, navigating the different policy areas is important for people to understand. Sheva, Robert, do you have the facility to share your slides? Because
we'll give it a try. But first, I just want to say that I keep looking for my Zoom emojis to like do applause and hearts and listening to everything that everyone on this panel has been sharing. And I wish we had many hours to be able to crosstalk and go back and forth. I'll just say, Patricia, when you were talking about electronic medical record, that was a really defining moment for HeartMath when we were embedded all of our tools in the electronic medical record of the VA. Because then you really, when you're, producing data that you collect, the beautiful thing about using an intervention like HeartMath is the end user is getting real-time data, both in biofeedback, but also in the ultimate biofeedback, which is that they feel better. And that makes these types of interventions that fall under the umbrella of social prescribing self-motivating and self-reinforcing, which is why they sustain long after the prescription has been given, because people want to do what feels better. And so really excited to have you on board and have you talking about that. That was a seminal moment for us when we were embedded in EMRs, electronic medical records. Rini, I cannot wait to speak with you more as well, because I am a licensed acupuncturist and doctor of Chinese medicine. Robert and I were invited through our work at HeartMath to be at the World Health Organization Traditional Medicine Summit in Delhi, India, where traditional Chinese medicine, which has featured profoundly, Rini, I hear, in your fertility journey. And in the early days, I ran what I didn't realize was a social prescribing clinic. I didn't have that language for it. It was called the Birthing Vision, helping women vision their births and birth their visions for women with infertility diagnoses. And we just got them together, having fun with each other, sharing their challenges. One young woman who had a complete hysterectomy because of cancer caused by toxin exposures at Beverly Hills High, where many young women in Beverly Hills were infertile, ultimately gave birth to twins out of that amazing journey that all of us took together. So many intersecting points between all of us. And at the World Health Organization Traditional Medicine Summit, what we learned is they hosted that summit because the member states came to them saying 80 to 90% of our populations would rather seek what in the United States is called complementary and alternative yoga, traditional Chinese medicine, support groups, many of the things, nature bathing, forest bathing, and time in nature with community. They would rather seek these types of interventions than allopathic care. And so the member states came to the WHO saying, we need help with this. And they founded the Traditional Medicine Summit that we were invited to with our many, many years of research. But I think we're going to just briefly try to share our screen so that we can give you a window into what this magic pill looks like and the kinds of results it produces in the over 2,000 peer-reviewed papers on the type of work that Robert and I do.
Please do. If you can't share, if you can't, don't worry. But we can always post the slides later as well, because I'll be doing a summary of this session, and I'll make sure that all the links and everything that we want shared can be shared. I'm just conscious as well, we've only got about 9.5 minutes left.
Okay.
If we can't share them, I want to bring Jim in, because I think, and then go to Rini as well, because I think Jim will have a fascinating insight into policy, because I see Jim does a lot of policy work, and I think it's really important for us to understand how the lobbying works as well. Jim, is that okay?
Yeah, I think sacred activism is what we call it. So, we give it a magical word, like the magical pills. And it's been really incredible. And I think, the difference between some of the things we're all sharing is, I believe, like Sheva and obviously Pat and others, that a lot of us are doing the social prescribing interventions, micro practices, etc. Definitely a HeartMath trainer and fan myself. But the reality is kind of transitioning people's thinking and helping them view things entirely different. Now, if you can imagine pretty much activating 10 million nurses around the world to how to be a major force in helping people flourish and helping systems flourish, then you can see the power of what we're up to as far as working with nurses around the US in particular right now. But, we've had a couple of major hits over this past year. We have a lot of political chaos, confusion. I'm sure you're all well appraised of that if you turn the TV on every day. But we're in a mess, and our society is under a lot of stress as well, but nurses in particular. And having had one experience just recently where the Department of Education decided to declassify nursing as a profession, was one of those wonderful, brilliant sparks that ignited my entire team. We ended up in Sacramento. I live very close to the capital of California, but we also sent people to Washington, D.C. And as a result of that brilliant move on the part of our government, it really got people engaged. And they saw the power of what their voice, showing up, standing up, being heard, and what that means when they're looking to actually harm the public by not making certain things available. And I would say all these interventions, many of us have experience in working with our systems to offer acupuncture. I can tell you my health system offers a lot of complementary health interventions, but we're not there. And our society obviously is looking at things differently. So we need policy. That's the bottom line, right, Gareth? We have to be actively engaged. So we call it sacred activism because it has deep meaning to people. And those nurses that showed up in Sacramento at the Capitol and met with their lawmakers, those people who showed up in Washington, D.C. from around the country, changed the course of that direction. And they have suspended what they intended to do, which was to make graduate degrees and additional funding that would be necessary for nurse practitioners, for any advanced practice people, to be unable to get loans, which is crazy. And so turning that around was a short, it's most of the things we do in sacred activism take time, like everything else in the world. But this was one of those things where it was a flare up. When you talk about fire, this is a really good one. It got a fire going in people's hearts. It really said, not on my watch. And the professionals leaned in, stood up, and showed up in those places where they needed to be. And they turned this around. And I think the same is true when it comes to human connection. This is, to me, that the social prescribing is a practical expression of who we are as nurses, as caring science experts. This is the work of helping society and communities come together in relationship with healthcare, not as patients, but in relationship to co-create, and nurses can play a pivotal role. So for me, that seems to be a really great strategy for us, is to shape policy, to shape curriculum, to move people toward meaningful interactions and honoring. The loneliness one worries me the most. And I can tell you, for 20 years, I've been saying to some of our students, you realize that some older people are coming to us and they've had no intimacy for over decades. So if you can use appropriate touch, if you can comfort them in some way, it's awareness, consciousness, and the ability to use their own wisdom and intellect to gear their practices in ways that are meeting needs that, quite frankly, have gone invisible because they weren't valued. And I think this work is so critical, and I'll leave it at that. I'm just thrilled to be a part of this group. I'm excited by all the presentations, and Patricia, I love your description of where you see opportunities and what you're working on, as much as I love Sheva and Robert and their work around the world. So I'm very, very pleased to be a part of this group.
Yeah, the good thing is as well, we're only starting. We're only warming up. Yeah. That's the great thing. That's the great thing. So we've got about 4 minutes left. I want to bring Rinny back in. I just want to touch on a point you made, Jim, there, and this is really about the leadership, but also understanding, because we have to understand how policymakers operate, and we have to also work with them carefully because they need our help and support as well. And the mindset has to change from being a policymaker, who I was one before, to enabling and creating value. So instead of always being fear-led, turning it on its head and realizing you're there for the state to create value. That's right. And I think the UAE and Dubai and Arab Emirates are doing an amazing job in that context. Rinny, just over to you. We've only got a few minutes left. I'd really like to bring everyone back in for a quick 30-second wrap up, but maybe in 2 minutes, just share your insights into sort of, and share the next steps that you're planning.
Okay, so look, having listened to everyone and thinking about the whole social prescribing modus of working going forward, all I would say to many clinicians and medical practitioners listening is you don't actually have to create anything new. A lot of these communities already exist. All you have to do is simply integrate them into some of your existing pathways. It takes a little bit of research just to find out what's out there. You make a phone call, you sign almost like a social contract, okay? And you get that activated. We talk about a lot of the ideas, but I love implementation. I like to make things happen. So my key takeaway from today is, yes, we've talked about wellness, we've talked about loneliness, we've talked about nature, so many really important societal and behavioral topics that can adversely affect us to turn to traditional medicines, however, or chemical medicines. My key message is you don't have to do that. There are yoga groups, yoga communities out there. There's cupping, everything. You just have to look for it and work out how to incorporate that into your existing offering and service that you deliver to your patients. Also, just want to say, very humbled to be with such esteemed professors and doctors from around the globe. Thank you very much for the opportunity, Gareth. I think, look, the future of women's health is not just about more treatment, but delivering better journeys.
Love it. And implementation, that's what we're keen on, because we've been definitely working very fast on implementation this week. So very quickly, I would like to give everyone a quick, just final few words, maybe 4 or 5 sentences. I'll go to Robert and Sheva first. Optimistic for the future.
Incredibly optimistic, Gareth. I mean, we see right now actively in our partnership with you several country possibilities orbiting us who are actively just that active. In fact, one of your speakers in the next section was representing our team for the country of India this morning, and we'll see how that goes. But there's an active interest on all levels of how do you bring the partnering, the economics, the policies, the implementation, the people. It's going to take a larger partnering of all these institutions, and that's present, and we're engaged.
we made that point earlier this morning. The slide I showed, the wider team, we've got a huge team, and we need an even bigger team because we've got a lot of work to do. There's a serious amount of work to do. Jill, just quickly to you.
I do feel the Recetas project has been sort of the nearest and dearest project to my heart. The last 5 years, I've learned so much. And the thing that I really feel hopeful about is shifting how we approach health, not just reducing deficits, but building the human capacities to lead meaningful lives with purpose and belonging, and creating interventions that emphasize group dynamics and peer support. If we can have more nature connection, these are the synergies needed to alleviate loneliness and so many other sequelae health effects. And what we learned is it's not so hard to shift the practice. And it's low cost. So I do feel hopeful that there's a way forward. I think if I think back like 10 years ago, we wouldn't have this conversation. So I feel now there's a lot of receptivity to the dialogue, the narrative, and wanting to be a part of it.
Brilliant. Just quickly, Patricia.
Oh, okay. Can you hear me? All right.
Yeah.
Well, I just want to say a few words like thank you to everyone for being with us today. I think as we look forward and ahead, the future of healthcare cannot just be about adding years to life. It must be about adding life to our years. And I believe that by integrating social prescription, we are designing a human first future where healing happens, not just in our hospitals and our clinics, but in our neighborhoods, out on our nature trails, in our art galleries and our shared spaces. So let's come together and build that future together. So thanks again. Much appreciation to you, Garrett, and everyone here today.
Thanks. Jim, final words, and then Rinny, final words.
Yeah, thanks so much. And I will bounce right off of what has already been said. I think, this is about human flourishing, period. And we're learning so much more. Let's shift consciousness with people. We can use sacred activism. It is all about compassion translated into action and partnerships and advocacy and innovation and measurable change. And we have the ability through policy, through our own actions to shift the consciousness and to support people in their own journey. So I'm really excited for that. Thanks, Karen.
Rinny, final words.
Just very quickly, look, I've got a banking background. So yes, we all want to focus on the human aspect, the social aspect, but there's $1 trillion gap which can be addressed if we invest more in women's health and fertility and wellness and outcomes. Like Gareth mentioned earlier, the amount of investment in women's health is single digits. If we invested more in this, there is definitely a return, which is good for business and it's good for society and the planet.
Excellent. Sheva, you wanted to say a word, last word.
Robert and I had the privilege of being in Bhutan in March, where the idea of gross national happiness was born to replace gross domestic product as a measure of value and progress for nation states. And what is so encouraging is while we are all meeting right now, the UN High-Level Political Forum is happening in New York. And I had the privilege of being last week in a meeting at the HLPF for Beyond GDP. There are member states all over the world that are committed to measuring their statehood value and progress, no longer by the dollar, but by the measure of human quality of life and all life. And that is what WHIS and Global Social Prescribing is here to deliver.
Absolutely. You heard it first, but just it's really important that we frame it correctly, and we should be very ambitious also. We keep it simple. The opportunity is there. Let's not be, looking for cost savings, because we are creating enormous value here. Remember, 80% the social determinants of health outside health system. The health system currently is a $12 trillion budget, which is only 20%. So just think of that as the growth opportunity that we have. Enormous. So thanks, everyone. I'm going to close this because I got to jump on to the last session, and really grateful for everyone's support, and we'll talk